Okay, good morning to everyone. I thank you for the invitation to this conference. So my speech is about the liver support, and we will see in this presentation the use of extracorporeal liver support systems in the pre-transplantation phase, in the liver transplantation phase, and then in the post-liver transplantation phase. So we see about acute liver failure and acute on chronic liver failure. We can see that the causes of acute liver failure are the usual one, or the intoxication of drugs, metabolic disorders, and above all the viral hepatitis or autoimmune diseases. And acute on chronic is quite different from the acute liver failure, because the mechanism is, of course, the induction of inflammatory by cytokines, by the DAMs, and by the defragment of complement. And so there are the different physiopathologic effects in this kind of pathology. And which are the indications of the artificial liver support for their use? We can see that the main indication is acute liver failure, viral or drug induced, or toxicity by other substances. But we can see that there are the indications of patients in awaiting a liver transplant for cirrhosis or other liver pathologies, but we have the indication even for the post-liver transplant primary non-function of the graft, or the delayed function of the graft after the transplantation. And we can see the history of the liver support systems in the years. We started with Mars in the 90s, the first one that could be used. Then we go to Prometheus, that is plasma absorption filtration. Then we have CPFA or PAP, and then the last one on the scene, there are the Cytosorb. This cartridge can absorb cytokines and other substances in the patients, so can detoxify the patients and regain the control of cytokine status and of the liver status. So we can see that the extracorporeal liver support can be used in different scenarios. We can see in this study that we have of 2020, there is a modern certainty that ACLS reduce the mortality in acute liver failure and acute on chronic liver failure. And we can see in this data that we have the reduction of mortality, but the reduction of the outcome of the encephalopathy, the metabolic encephalopathy in these patients. We observed that we have a more prominent reduction of mortality with artificial devices than the bioartificial ones with that are more experimental at the time. We can see in this paper that all ACLS devices are safe in the use on the patients, and only one observation is that in some cases we can observe thrombocytopenia with the using of this kind of devices. We have to remind that of course patients in acute liver failure then acute on chronic liver failure can get well sooner than ACLS. But of course, in all these patients, we have not so strong evidence of the reduction of the mortality. And so, of course, large RCRT studies are needed to demonstrate this reduction of the mortality. ongoing in the before phases of liver transplantation. We can see this paper from Finland, in this we can see that it's crucial to recognize the right patient to be transplanted in acute liver failure, because it's a crucial point, because more or less 50% of these patients die in the waiting list before getting the liver transplantation. And we have to underline that it's better to avoid the avoidable transplants, because in these cases in which there is the possibility, the chance of the liver to regain its function, we don't expose the patients to a great operative risk of the liver transplantation, and above all, a lifetime immunosuppression state. So, of course, in Finland, they used King's College criteria to decide who is which patient go to the transplantation, and they use ACLS only in this situation. So the indication to use extracorporeal liver support is only in the patients that are already listed for liver transplantation, or in case of ingestion of lethal dose of hepatotoxin, for example, from mushrooms. In these cases, they use the extracorporeal liver support to detoxify the patients and to regain the liver functions. And so we can see that they observed a different mortality rate, even in the patient that don't go to liver transplantation, but even in the ones that go to the transplantation. So they observed a different mortality rate in this group of patients. Of course, extracorporeal liver support can be used even to bridge to transplantation if they be used in the late phases, in which the patient has already come the multi-organ failure. But if you use this support in the early phase, you can bridge to recovery, or to return to the previous liver state of the patients. So it's crucial even the time when you use this kind of the support of the liver, early or late. Of course, in other paper, we see that the hepatic encephalopathy that is present in the pre-transplantation phases correlates with the post-transplantation encephalopathy and neurologic dysfunction. So it's very, very important to detoxify the patient before the liver transplantation, because this can help to a sooner, to a rapid regain the neurological function after the intervention. So it's crucial in the before phases to use these devices to detoxify the patient before the intervention. Now we can see the phase of the liver transplantation, in which we know a precise mechanism, that is ischemia reperfusion injury. So we can see that is inflammatory phases in which are involved, of course, cytokines, complement, and of course the direct insult of the ischemia. So the physiopathology of ischemia reperfusion damage is, of course, the vascular alteration, of course, a great inflammatory process that arise from the ischemia, and then the reperfusion in the graft. Of course, the cytokines, TNF, alpha, and IL-1, and of course, even the fragment of the complement, in particular C5a. all these substances create a great inflammatory state that give a damage of the liver, but not only the liver, but of all other organs. Of course, there are determinants in the graft that can get worse the patient with ischemia reperfusion damage, and of course in this one we have steatosis, but even cholestasis and bile acids. Bile acids in particular induce inflammation associated genes in hepatocytes, and induce, of course, contribute to inflammation and hepatotoxic effect that can be aggravated by pro-inflammatory effects of the cytokines. Ischemia reperfusion injury is unavoidably typical of solid organ transplantation, because we have, of course, the ischemic phase because the graft is put in the receiver, and that can give the post-reperfusion syndromes that is a hemodynamic instability at the reperfusion that, of course, is associated higher risk of allograft dysfunction. In particular, in that grafts that are used up to now as extended criteria donors, of course, marginal grafts, or that comes from donors that die from cardiac arrest, of course. And there are some experiences that use the perfusion of the graft, even from hypothermic oxygenated perfusion, in using even the Cytosorb cartridge that can moderate hyperinflammation during the transplantation, but even used with the graft, with the back-table graft. So the perfusion with Cytosorb seems to be effective in reducing the non-function of the graft after the transplantation. And this is the situation in which we have the primary graft dysfunction that can be seen in two aspects that are initial poor function of the graft or the primary non-function of the graft. Of course, the first one is more reversible than the second one that in many cases needed a retransplantation of the patient because the graft going to non-function, irreversible non-function, of course. So in these cases, of course, the extracorporeal liver support can be used to reduce the inflammatory damage and to try to get back in the situation and to allow the graft to regain its function. Of course, there are the determinants and the risk factors of the primary function in liver transplantation, and we can see there are, of course, the steatosis or the portal vein thrombosis before the transplantation, donor from cardiac arrest, cardiac death, of course, a prolongation in ischemia time more than 12 hours, age of the donor measure of 60 years, and of course some determinants of the recipient. There are bilirubin, the disease etiology of the patient, and of course the intraoperative use of the plasma, more than 30 units. And we can see that in this scheme, bilirubin and ischemia reperfusion are the major determinant of course, the primary function of the graft. There is an interesting paper of 2020 in we can see that in donor from cardiac arrest, of course, we observe the cell-free DNA level in the plasma of this recipient. And so we can see that we have a low CF DNA, we have a superior survival and a reduced inflammatory state. On the contrary, we if we observe a high cfDNA levels, we have inferior survival, more granulocytosis, and more C-reactive protein, so a inflammatory state. And the colleagues observed that the use of CVVH, cioè the continuous venous-venous hemofiltration, with the cartridge of Cytosorb, we can reduce the levels of cfDNA, and in this patient seems to have a better prognosis if we have a reduction of this cell-free DNA. So a CLS in this case can be useful to regain the liver function of the graft after the transplantation. That it's, I think that it's an interesting point to analyze and to consider. Of course, Cytosorb have a larger spectrum of the absorption, can absorb cytokines, of course, DAMPs, chemokines, even bilirubin, bile acids, so give a great detoxification of the blood of the patients, and so can get together the purification from the hepatotoxin molecules and the detoxification, then again the control on the cytokine status of the patient. So there are two goals in the same cartridge. We can see the spectrum of the absorption, the comparison between Cytosorbs and Mars absorption. We can see, of course, Cytosorb can absorb even pumps and dumps that are involved in the inflammatory damage in this patient. And now we can see our experience. Of course, is a single center experience of 15 years of activities. We used more or less all the extracorporeal liver support that are present at the time. So we used Mars, we used Prometheus, PAP, CPFA, and Cytosorb. And we can see that, of course, there are difference in mass balance purification, of course. We use the total mass balance to understand how this system can purify, how much these systems can purify the patient. And we can see that Cytosorb have the major detoxification efficacy in confront of the other system. Of course, I repeat, is only our experience of our single center. But there is another study of the group of Rostock in which in vitro demonstrate the same results. So Cytosorb compared to Mars remove more bilirubin, more bile acids during the treatment. And another characteristics, another features of Cytosorb is that the purification capacity falling in the time during the treatment, but even at 24 hours of treatment don't go to zero. So the cartridge can absorb even at 24 hours of using. So this is one of the determinants that can justify why Cytosorb remove more molecules than the other systems. But another determinant we can think that is even the duration of the treatments, and we can see the other treatments that have a duration more or less 4, 6, 8 hours. On the contrary, Cytosorb can be used for 24 hours. Of course, we have major removing of the molecules due even to the major duration of the treatment, of course. Another characteristic that Cytosorb have in comparison with the other systems is that can be used in in all CVVH circuit. So you can use in series in the circuit of the dialysis. And so the importance of this characteristics is that you can use the regional citrate anticoagulation. In other system, you have to use anticoagulant, and in this patient can be a great problem because they have already an alteration in coagulative aspect. But with Cytosorb, you can use usefully the citrate. And we studied this situation, of course, and pay attention at the value of the calcium ratio. We can see that if we have a ratio more or less of 2, then 2.5, that is the limit of the citrate accumulation, you can use safely even the citrate, even in acute liver failure or in severe failure of the liver of these patients. So there is an important aspect to consider, because you can use Cytosorb without anticoagulants. Another characteristic, another features of the Cytosorb is that remove even total bilirubin, so can remove direct bilirubin, but even indirect bilirubin and bile acids. So can remove all this kind of the molecules, and it's very important even for the molecules don't bind to albumin. So what we can conclude analyzing the situation and all the kinds of the extracorporeal liver system, that all these treatments are effective in remove bilirubin and bile acids. There are, of course, substantial differences in the duration of treatment for each type of technique. In all, there is essential to use anticoagulation, but Cytosorb, in comparison to the other systems, can be used even with citrate regional anticoagulation and not using anticoagulants drugs. Of course, these treatments can be used for all cases of acute liver failure, acute on chronic liver failure, or liver transplantation with primary lung function, or sepsis that following the liver transplantation. So despite the etiology, that these treatments can be used successfully. And focusing on Cytosorb, we can say that is clearly easy to use, because it's cartridge that you use on your dialysis machine. So it's very, very easy to use. Of course, the training of the physicians and the nurses for the use of this cartridge is very, very short, because it's very easy to use. It can be used, as we said, with any type of CRT circuit. The efficacy of the subtraction and depuration is present for all the duration of the treatment, and in our experience of our center, is superior to other systems. We observe even that we have no release of the absorbed molecules even after 24 hours of treatment. So we use the Cytosorb cartridge even for 30-35 hours, but we don't observe the release of bilirubin or bile acids in the patient. In our experience, we didn't see a significant loss of albumin or platelets. And of course, as we said, Cytosorb can remove even albumin bound, but even the molecules didn't bind to the albumin. So, in the conclusion, we think that, of course, more trials, more randomized control trials are needed to demonstrate surely what we can see in our clinical practice in terms of improvement of clinical condition, restoring liver function, and to have a good bridge to liver transplantation with patients we have the indication to liver transplantation for their condition. And of course, we think for our experience that Cytosorb is very easy to use in any hospital settings, and so it's very important to have the possibility to use this kind of system. Thank you for your attention.